which is Mr. Ramphelane Morewane. As we've introduced, he is the DDG at Department of Health. Please note, I see some hands. Please note that you can put your question into the chat, and we will answer those questions when we have our Q&A session towards the end of the webinar. So please do feel free to put your questions into the chat box, and we will answer those. Thank you, Mr. Morewane. Over to you.
Good morning, and good morning to the CEO of Higher Health, and thanks very much for such powerful and very, very inspiring, intro and into the purpose of this webinar. I had prepared some slides, but if they are not available, I can still talk to them. And the pity is that we may not be able to see them. But just to say, to echo the sentiments expressed by the CEO, Professor Ramnik, that reliance on foreign aid has always had its own problems. And some of us that have come up through the ranks to work within donor organizations and with donor organizations, there's always been what we call the life after donor funding. So when this situation happened, it wasn't anything new, except that it was just sudden, such that we didn't have enough time to respond. Now, what do we do? I'm going to very, very quickly, really, very, very quickly take you through some of the slides. And I don't intend to read all of them, but I really want to just take you through the key highlights of the work we've done and the work that has been done and what we continue doing. The first thing is that the South African government got notified about the withdrawal through various sources, unlike what is normally the case, where you would get a communication coming through. We didn't get that. So we got it through those that are affected on the ground. Again, it just shows you of how communication can go wrong, or sometimes it may not even happen the way you think. So I'm going to go very, very fast on these slides. I'm going to just deal with a brief introduction and background. And you'd remember that I'm sure just now, Prof spoke about 27 priority districts. I'm going to deal with that. I'm going to show the resources that are available for HIV/AIDS and TB response and the implications of the executive orders, mitigation measures, and I'll conclude. The purpose really is to look at the impact of the USAID's funding decision and the strategies to ensure continuity of HIV and TB care within the post-school education and training sector. We want to do this in line with the purpose of the webinar to ensure that no student is left behind in accessing life-saving medication and treatment. And in that area, we want to focus more on ARVs, TB treatment, pre-exposure prophylaxis, and post-exposure prophylaxis. Just as an introduction, I've already covered this. So because we didn't receive any formal communication, but we didn't want to wait until we received formal communication, we started acting. Just the list here, it just shows you the number of people who have engaged in trying to firstly make sense, but also pleading for support, but thirdly and most importantly, assuring those that are affected by this withdrawal that we're doing something. Having met all important people, you'd realize that towards the end, we then say, we engage PLHIV sector, one of the 18 civil society sectors of SANAC, and in fact, we intend meeting them now face-to-face on a date that will be communicated soon. but much sooner we'll meet with them. We've already met the implementing partners because we're meeting sector by sector, subsector by subsector, so that we don't muddle issues. We are also engaging on finalizing the implementation of the sustainability framework that's developed by SANAG. And regarding our relationship with higher health, we have come a long way, as my colleague has said. I mean, on the campaign of First Things First, we are together. Capacitation of higher education health providers on various methods of work, contraceptive, adolescent, youth-friendly services. We're also training those that are rendering services in the campus clinics. On NIMART, we work closely with provincial managers to support the outreach, particularly for the clinics that are in the catchment space. Youth festivals and TVET colleges. I've personally been there with Prof. We know what it means. We've been on the ground. And that all higher health events are held, are planned jointly and held together. And therefore we work hand to hand, hand in hand with the higher health institution. Now, the 27 priority districts that Prof spoke about are here. The listeners, participants on the platform should be able to recognize their districts. In Eastern Cape, we've got 6 districts, 1, 2, 3, 4, 5 districts. In Free State, we've got 2 districts. In Gauteng, we've got 4 districts. In eThekwini, we've got 7 districts. I mean, in KZN, we've got 7 districts. In Limpopo, 2. In Mpumalanga, 3. Northwest, 3. And Western Cape, 1. So certainly Northern Cape has no district that's supported by PEPFAR. For one reason, they really didn't have a high burden district. This slide just shows the deployment of the resources, human resources, that's there on the ground. In total, we've got 271,606 staff members that are in the patients facing service delivery points for HIV and AIDS. But if you look at the middle row, middle column, you'd see there we've got 256,000 of them that are funded by the Department of Health, which means we're funding the biggest chunk, and 15,000 are funded by PEPFAR supported partners. So you can see that it's about 4.5 or so, 4.6%. Now this slide just shows, again, to date, how much money we are spending. South African government today, as a government from public funds, we're spending 74% of the efforts to address HIV and AIDS and TB, and private sector is giving us 2%, which mainly comes from medical schemes. And both public and private sector together, they're giving 76%. So the donor funding is about 24%. What does it mean? It's 17% of PEPFAR and 7% of Global Fund. So the rest you can read as to how much it does it really mean. So we need to deal with the implications of the executive orders. What did they do? Once this was announced, we knew that all projects that are funded through PEPFAR in line with country operational plan are in trouble, because we signed our COP23 just last year, which was running for 2 years, 2024, 2023, 2024, 2024, 2025. So it will be ending in September, and I will deal with it in a second. And then we knew that patient care and other health outcomes will be affected. Achievement of the second 95 of our 95 targets going to be affected. But we know that we have done some work in that. And we're also on the verge of implementing transition from 3 multi-month dispensing to 6 multi-month dispensing, as announced by the Deputy President. We know that one also may take a knock. In terms of provision of pre-exposure prophylaxis, we also knew that it was going to be affected. In terms of scaling up of targeted universal testing for TB, and also linkages for drug-susceptible TB patients, and those that are drug-resistant, that was going to be affected. So what did we do? The department then issued a circular to all provinces to ensure that there's continuity of care. So this involved the redesigning, rearranging the work, redeploying the staff, doing task shifting, and prioritizing the 3 multi-month dispensing, encouraging HIV self-testing on the ground. And also that we should implement the 28-day delay collection allowance for patients, because sometimes patients delay to take their treatment. Now, on the long term, we are actually doing a prioritization exercise. We've received the spreadsheets that deal with the number of people that are on the ground. We're analyzing them. In fact, we concluded that work yesterday. What is left is for us when we meet with National Treasury to be very clear as to what we are asking for. When we meet with any funder, to be very clear what are we asking for. Because we could not go to them without having consolidated the work that we need to do. So therefore, as I go towards conclusion, what do we need to do? We need to make sure that no person living with HIV should fail to take or stop taking their ARVs because of PEPFAR withdrawal. So we're very clear that there are many students that are in the campuses that are relying on these services. In fact, we are going there, and I'll deal with the last two bullets just as I conclude. So we know that many students in the campuses are reliant on the services for pre-exposure prophylaxis, which we know now that the PEPFAR is not supporting. We know that they are relying on the PEP, post-exposure prophylaxis, and we know now that they are not being supported. But I must assure the audience here that with regard to provision of ARVs, South Africa has always provided and bought its own ARVs. 90% of the stock that we have available now and into the future is provided for from the fiscus, and 10% is provided for by Global Fund. We woke up this morning to the news that Global Fund intends supporting us, and I'm sure in a moment they'll be able to send formal communication of strategies that they're going to put in place to make sure that we don't fail because of the withdrawal. So what are we doing? We're calling on all South Africans that are HIV positive to return and remain on treatment. Why are we doing that? We know among the students in the tertiary institutions, there's 1.1 million of them. They're part of the 1.1 million of those that have disengaged from care. We're saying in order for us to reach the second 95, we need to get 1.1 million people so that we can close the gap. We launched this campaign on the 25th of February, last week, Tuesday, so we are inviting people to come back to treatment. And secondly, because there are many young men at the institutions of higher learning, we want them to be part of the broader campaign of men's health called Better Men for Tomorrow campaign, which was launched and supported by the Deputy President of the country. Thirdly, we're saying all campus clinics must have referral system to the neighboring health facilities in the communities and vice versa, because we want to encourage the clinics also that are seeing patients that are stable and need to be down referred. They need to be down referred to the campus so that campus clinics and the clinics in the locality can work together to make sure that no one gets lost. Number 4 is that the packages of care that are delivered at the campus clinics are aligned to those that are delivered in the communities. Why do we want the alignment? We want to make sure that there is nobody who has difficulties in the continuation of taking treatment. Because if they are not aligned, when somebody lands at the campus, they may then find it very difficult. And lastly, and most importantly, we want the campuses to be pick-up points for centralized chronic medicine dispensing and distribution, which is called CMMD. So with this, we are saying everybody who is in the institution of higher learning should not despair purely because PEPFAR has withdrawn. We want to assure South Africans that once we go with a consolidated piece of work that we're doing to those that are funding us, we'll come back and reprioritize. And what are we reprioritizing? We're going to have to say, firstly, what are the critical services that we do not want to drop the ball on? Because for us, both treatment and prevention are the two handles of the same plow. You can't hold one and leave the other. We need to start mopping the floor as we have been mopping the floor with treatment. But we also need to close the tap through prevention mechanisms. And we're looking forward to the day that the long-acting injectables will be authorized and approved so that our people can then be helped with the long-acting injectables, which will reduce their visit to facilities, but will also make sure that they walk around protected. And the other point that we need to emphasize is that the work that we're doing would have to make sure that we stamp out sexually transmitted infections, because those may lead to major complications in terms of reproductive health. Number 2, we also need to make sure that nobody falls prey to the unwanted and unplanned pregnancies, because that are major disruptors in terms of economic development and academic progress. So let me stop here and Chair and just say, as we are the Department of Health, we are available to work together with the 3 groups that have been affected by this. And we categorize these groups as follows. Firstly, I call these groups. First group is 1, the researchers that are doing health-related research, working very hard in the institutions of higher learning and research establishments. They are very important. Number 2, organizations that have closed down, which are providing employment to some people that were funding the students that are at universities, whom without that funding, their own children may find it very difficult to continue with the studies. Number 3, and most importantly, but last but not the very least, is people that were receiving these services from our health facilities would want to say to them, we are planning to make sure that we sustain the services that were rendered. Even though we know that the PEPFAR is gone, we're assuring you that no one will go to the services and come back without having services delivered. But again, we know that other services of the key populations may have to continue to be rendered in spaces where people are very, very, very discreet, because they would want to be seen where there's no stigma and discrimination, perceived or otherwise. We therefore respect that and want to encourage collaboration in that regard. When we emerge out of mobilization of resources, we should be able to say, how do we cover the whole landscape as far as possible? Thank you very much, Facilitator and the audience.